Right, and for those who are joining us remotely, we're going to the Adobe Connect will be down during the hands-on session, but we'll be back up at 3:15 for presentations. All right, we're going to go ahead and get started with the second half of the afternoon here. Russ will give an overview of Corey and the Greater Plains Collaborative, and then I will talk after him about data. And if you do a data request, what that data will look like, what you can do with that data once your data request is fulfilled. I will show you kind of the raw data as well as how we pull it into REDCap. I went ahead and handed out some surveys. If you guys have a chance to fill out the survey, give us any feedback. I'm kind of interested to know if you think this should be a one-day thing, if it should be 2 days, if we should do more of one thing or the other. Any feedback we would appreciate. If you fill it out and just drop it off on that little ledge up there maybe on your way out, that'd be great. I'll probably send it to, so if you fill it out on paper, ignore the survey link, but here we go.
Okay, so I'm going to talk a little bit about, we're doing this work, we've done this work here at KU with HERON, and then we've been part of a project to kind of bring data together across the whole country. And I think it's worthwhile introducing, because the vision here is that the work you can do here, as we work together across the country, you can then replicate that and see if this generalizes to the whole country. Has anybody ever heard of PCORI? Is there anybody who does not know PCORI? Okay. So I will talk a little bit about this overall project. I'll give some quick examples, and then we'll turn it back over to Tamara. So basically, there is a funding agency called the Patient-Centered Outcomes Research Institute that, along with other leaders at the NIH, have kind of thought that clinical research is well-intentioned but flawed, because a lot of, when you get down to the actual practice of care, a lot of the decisions aren't supported by evidence. We've got, rampant issues with disparities in outcomes that aren't getting better. And then when we do trials, they work, but it takes a long time, costs a lot of money, it's unreliable, it doesn't answer questions. And the clinicians really, talking to Anna, it's hard to get the clinicians to give a hoot about doing your dry eye trial, right? So we got to figure out, can we do this better? So one of the things, like while we were here looking at HERON to figure out how you can search is, if we could link data together across the country, that could help. Because typically what happens in research is each project is its own little project. It doesn't build upon any infrastructure from a prior project. So the goal of this overall project is to bring data together. And not just bring data together, but actually let you do trials. So it's not all just about looking at data, it's actually about thinking about how to conduct trials. So they funded this larger effort called the CORNET essentially last year. We're wrapping up the initial 18-month kickoff, and we'll find out next month if we're funded for Wave 2, which will be another 3 years. I feel pretty good about it. And I'm mainly going to talk about our side, which are what are called clinical data research networks composed of health systems. There's also a side of the network which is focused on patient groups. So there's actually a group of patients with vasculitis working together, people with rheumatoid arthritis, people with heart disease are organized into patient networks. So they want to improve the nation's health care by conducting research on a large scale, representing most of the country, and support the ability to really kind of learn from that research. So not just research by itself, but figure out how can we do research that's tied a little closer into how care is delivered. So what we've been building is really allowing people to access data in our network across the Midwest to let people work together, look at questions, bring in richer sources of data, have a process where it's not just researchers, it's engaging patients and clinicians and health system leaders, and then doing both observational studies, looking at data, as well as doing interventional studies. And then allowing people to collaborate with it. So when they funded it last, I guess the funding announcement was actually in December 17th of 2013. The funding actually started in March, but to give you an idea, they covered most of the country in one way or another. So what we are building in the Greater Plains Collaborative is we're one of these clinical data research networks that will have at least 1 million people. We'll have the data managed like you see in HERON, where it's de-identifying people so that we can allow researchers to access information without needing to get individual information immediately. And then really a big focus is bringing in the EMR data. And then each of us are kind of looking at different conditions. So for our network, we're taking a particular focus on looking at Lou Gehrig's disease, breast cancer, and then every network is looking at what originally was called the obesity cohort. And Ann Davis has been working with us on this a bit. But then they kind of relaxed the condition and said, really, we want to look at weight, and healthy and unhealthy weight. It's kind of restrictive just to kind of look at only a period of obesity. So let me just roll through this. So our network is this set of places. We're adding 2 universities in phase 2. We're adding Mizzou and Indiana. So that's kind of who's in our network. When we add Mizzou and Indiana, we'll be well over 11 million people essentially who we have data on. A lot of hospitals. Kind of summarize. And we use, again, the HERON technology you use with I2B2 and using common scripts as kind of a core technology, as well as using REDCap to deploy surveys and integrate. We've had a series of meetings last year. We had a really nice engagement meeting, bringing together people, trying to get patients activated to work with us. If people know Kim Kimenow at all in family medicine, she works with us to lead engagement with patients. And Cheryl Jernigan, who's very active in the Cancer Center and the Komen Foundation, is our lead patient advocate. So the first part, the goal would be to figure out how can we run a trial in the health systems that fits into healthcare operations. So one of the trials we proposed, we're waiting to find out if we get funded on, is could you do an ALS study for Lou Gehrig's disease where you get the patients to record their functional rating scale. So you might be collecting it in the hospital in a flow sheet, and it looks like this, but then you may want to send out surveys to patients at home to get them to fill out their functional rating scale data. So that's kind of an example of the capability we would want in the EMR and in REDCap, because actually you can build a lot faster in REDCap than you can build in the EMR. And if it's for research purposes, you may want to splice them kind of in and out of each other. And then we want to do work as well to kind of build into both the patient's perspective of MyChart or the Cerner patient portal, as well as right in the EMR, the ability to nicely alert people that this might be a good patient for your trial. So like in your dry eye example, ideally we'd get everybody consented, we'd figure out how can we let people know, hey, it looks like on your schedule tomorrow there's a patient with dry eye, doesn't look like they're on any anticoagulants or glaucoma meds. They might be an ideal fit. Would you refer them to Anna? That would be your dream situation. And an even bigger dream situation is later on if we could actually harvest the note and know that the result of the staining was not one that would further exclude them. So that's the dream, is how can we better tailor data to help support recruitment for a trial. And we may want to do work exactly, in the case of PCORI in general, so these are complementary. So HERON, and all you're seeing here, was really created by the CTSA program, Frontiers here, which was driven by the NIH. PCORI is, so CTSA, NIH, more general research, but probably a bias towards new discovery. PCORI, the Patient-Centered Outcome Research Institute, is interested in comparing the effectiveness of current treatments. So talking to Ryan, you may not be as interested, I'm making this up, in developing a new drug, but you may be very interested in saying, how do we optimally manage the refugee population? And are there particular approaches to engaging those patients that would work best and make a dramatic difference in those children's healthcare? That might be more PCORI oriented towards funding than you would see in a typical NIH trial. So we want to build an infrastructure that can serve both. But it may come down to, in a comparative effectiveness intervention like for ALS, what you'd be looking at is they have lots of drugs they use to try to manage drooling, let's say. That's a bad side effect, that you develop with ALS, and if you're not positioned correctly, could cause choking. So they may say, we've tried patches, we've got other treatments, but because the patient population is so small, we've never been able to get the funding to do a trial big enough to see what the definitive answer is. PCORI ideally is interested in answering those types of questions. Not that we should develop a new drug for drooling, but that we have not had an opportunity to answer a question for the population that's kind of a rare disease that's scattered. So when we look at doing this type of work, a lot of the focus is on getting complete and comprehensive data together. So as I was talking a little bit before about sometimes you've got almost too much data, where you've got billing diagnosis, you've got clinical diagnosis, you've got AHRQ measures. That's good and bad because it helps you fill in a more complete picture of the care. So this is a picture we put in for the proposal that kind of summarizes what we're talking about. If you were to look at breast cancer cases at KU, and you were to look at time before and after their initial diagnosis, you would see that some things make sense. Very few people have radiation oncology before they're diagnosed. that would make sense that it's very lightly shaded. Dark shaded means data is collected. But other characteristics, these people probably have a BMI. It's not like they don't have body mass index before they had breast cancer. It's just we don't have that recorded very often. Or we may look at other characteristics like, do we know they have cardiovascular medications before or after? The goal would be to try to supplement our data by working with claims data and other sources to kind of get a more complete picture of care, or at least well categorize which patients are kind of KU patients that come here frequently versus which patients come here for tertiary care. So a lot of the initial work we've been working on is, you've been browsing HERON right now. We have another website called Babel that takes the hierarchies out of Babel and takes hierarchies out of our other partners in Nebraska and Milwaukee and Children's Mercy and puts them all on one site. So at least, even though you can't yet search it right away, you can get a very good feel for what type of data is out there. So you can see things like in Milwaukee, they do have a lot of the same types of data we have. Same thing goes, you can see up in Iowa, they've got a fair amount of patients with procedural data that one can start to look at. Dallas, Texas has got some really interesting data around cancer care that's more advanced than what we have. So that's kind of giving you a feel for, so imagine searching HERON, and you can do this today. We have the governance worked out so that if you build a query, and May did this the other day to help prep for a amputation trial that Joe Lemaster is leading here, we just have built queries to see how often do people have foot ulcers, predominantly, and then how many develop amputation, and then we're looking to replicate that across our sites to kind of get an understanding of what might be good places to also implement this trial. So you can do that type of work today. And if you're interested, you can contact Tamara as you're developing that protocol. So let me show you more the interventional side, which is the first trial. So the leaders up at PCORI were trying to think of how can we show people what we could do that typically has been very expensive and hard to do. And at the time, one of the leaders of PCORI, he's left. Has anybody ever heard of Rob Califf before? He was the head of translational research for Duke, and he's now the deputy director of the FDA. And he thought, he's a cardiologist, world-renowned. He says, we got a problem. Okay, so somebody has chest pain, right? The guy, let's pretend we're Saul. And he's taken to the emergency room, and he learns out, I had a heart attack. And the doctor told him he's got plaque in his arteries, and he gets discharged, and he's told, take an aspirin a day. So he does that, and he talks to a buddy of his who says, you know what, I take a baby aspirin, 81 milligrams, and I think it's because my doctor says it doesn't cause as much bleeding and bruising. So Saul's kind of wondering, what should I do? Am I right to take 325, or should I take what my friend takes, which is 81? Because he does a lot of work as a carpenter, and he's worried that he might pick up more bleeding risk because he's always, dinging his fingers and bumping into stuff. So that's the basic question for this first nationwide trial is we've got this drug called aspirin. That's a wonder drug. Ironically, when it was originally marketed, it was marketed that it doesn't affect the heart, when in fact we know it does affect the heart. But no one's ever known for patients at risk after they've had, a heart attack or had a catheterization, what's going to provide the most benefit? Should you take 81 or 325? So a very simple idea is to look in data that we have in our EMRs and try to record, find out who would be eligible for the study. And normally, if you look at a clinical trial, the amount of money you get paid after all the dredging to get somebody on the trial is in the thousands or $5,000. I don't know what they're paying for. What are they paying for your trial? Do you know what they're paying for accrual? Yeah.
For each patient that completes every exam, it adds up to about $2,000.
Yeah. So that's less than some of these big complicated trials, but still a significant chunk of cash. So they're hoping we can figure out by using data we have and the ability to contact those people more seamlessly through the clinics and send them emails, maybe we could recruit a lot of people and instead of at the rate of $2,000, at the rate of $200 a patient to get them on the trial. So they're going to have us, basically what we're working to do is screen our sites and figure out how many people look like they meet the eligibility criteria, and then how can we elegantly work with cardiology and family medicine practices to then contact those people. as much as possible via email, and then direct them to participate in a website run by one of the patient power groups that's called Healthy Heart Alliance. And then they would go through the consent process online, get randomized to the dose, and then do all their follow-up there. And then we would link with them to say, as we harvest the data out of the EMR, do we see any higher rate of hospitalization or bleeds? And then they'd also, at the end of the study, link in data from CMS to see if claims have gone up or down on folks. That's the dream. So, you know, if you got this right and we could do this type of trial, it would save, you know, this is a big question. There are tens of thousands of people at risk here, and across the globe, it's in the hundreds of thousands. So it's really important globally because, you know, there's a lot of people in the rest of the world where this type of question could have a big impact on life across the country and across the world. So that's kind of an example of thinking about a trial. So as you're thinking about how this can help people, that would be the goal, is as we develop these techniques, as we're talking about how can we help you get in touch with the clinics that, you know, could more seamlessly recruit. That's kind of a goal for PCORI. So the other thing I just wanted to cover up in this, because I gave this talk to the American Pain Society, is, and we've hit upon this in the tutorial today, is so some data is really well standardized, like a CPT code, a procedure code, or a diagnosis code. Other data, like I said, is kind of the wild, wild west initially, like pain scores. But when you look at KU, we've got beautiful, beautiful data on pain. And so there is a goal here as well to get at the data that isn't as well standardized. So, you know, if I want to look and say how many people have had a high pain score who've been through the emergency room based on patient acuity and have had been exposure to opioids, there's a lot of people here at KU I can study. And I could then turn around and look, these are flow sheets from Milwaukee, who's also brought them in, and I might see that they're documenting pain assessment a little differently. So we want to also work over time across the network to say where there's data that's more novel or not as interoperable, and work towards interoperability for that. And so our colleagues at Nebraska are leaders in terminology, and they're looking to evaluate are some of these standard ways of describing pain using the LOINC standard that we're using for labs. Can we replicate that for clinical measures like vital signs and pain? So if you hear about the Greater Plains Collaborative or PCORnet or PCORI, know that we're part of that. As I showed you on some of the prior slides, think about, and it's a two-way street. You know, there is this data that's emerging from all these places, but it's also built on good collaboration. So if Tony Kovac knows the anesthesia department at UT Southwestern or Milwaukee or Marshfield Clinic, if you've got collaborators there where you're thinking about a project that you'd like to look at, we could explore, you know, as you're working towards a grant in that area or quality improvement area in that project, it might be an opportunity to benchmark between the institutions, which then really that's what people demand for the next state of research is what you found unique to KU, or does it generalize across the country? Did that sink into people? Is anybody pique your interest? So I'll show you, since we've got a minute or two, and I went really quick, which was my goal, is again, there is a website. If you're interested in just poking your head around, or nose around, I guess, you know, poke your head in the website. This website, if I can type correctly, we can pass out, Tamara can pass out passwords to this. And right now, and there's actually a tool we have which lets people copy queries up from their local account and place them on here. So you can do work where you can build a query locally, and then there's a little techie trick where you can copy and paste it out of HERON and then post it up on Babel where you could share it with a colleague at another institution. So Babel, since we're looking at this here, what you're seeing here is it looks exactly like HERON, except for instead of only having KUMC trees, it's got stuff from Children's Mercy. It's got some folders we're trying to develop, which are going to be standards for our network. Here's medical, this is the Marshfield Clinic in Upper Wisconsin. Here's Milwaukee. Here's Iowa. So you can start to get a feel for what types of data are out there that various sites are contributing to this network. So even though we don't have everything fully aligned, if you wanted to just get a rough sense of let me see here. So if I wanted to search for foot ulcers at KU, I would see that foot ulcer of other part of foot, the 70, this category of diagnosis code, if I look at 707.15, I could turn around and say, how many people might there be at Milwaukee potentially? Oops. See if this works. I hit the button right. Come on, computer. Any ideas? Okay, that should have ran.
May not, yeah.
It's not foot ulcer, it's ulcer other part of the foot there. But that gives you a feel for, similar types of data are becoming available at other sites across our network. So it's kind of neat because this has been one of the first opportunities where you can sit in one spot and just get a feel for what types of data are available at different sites that might want to participate either in a trial, or if you want to do like you were looking at Seroquel usage, you can get a pretty clear sense that was Seroquel services they're on. Are they monitored for glucose?
Low dose.
Yeah, so here in San Antonio, you can get a feel for how many people might have the diagnosis like antipsychosis that you want to exclude. You could build a query locally and then upload it here. I think what you would do is you would basically come in here. This is probably, well, let's just do the most simple example. Here's the gastronomy status. Run it. Do I run it first?
It won't.
What?
Yes, you run it, and then you click on the XML.
Which is here.
That one right there. And copy in the bottom one.
This one?
Yep, there's an area that says query definition, and you copy the part that says query definition in the red.
Which is?
So it ends here. So highlight and copy until you see the top of query definition, which is go down a little bit. Right here.
So let's see if this works.
If you copy it, and then go back to Babel, and go to Analysis Tools. Paste it in the box.
Oops.
Now click Find Patients at the top. There you go.
Pretty neat. So then I've brought that query from my local site, even though it's a very trivial example.
It'll bring over your dates.
I can copy it up here. I just give it a name. Oops, stop that. Stop that. And so what it's doing then is that query has been copied up here once it finishes, so that I can then reuse that. I can take that query and then I could tell other people in the country, here's what I've done. So what we're using this for would be somebody in Minnesota, let's say, wants to run a query on our site to say how many people have blah, 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 blah. They can copy up their query here, and then Tamara can rerun that query locally and give them the answer back. Now, there's technology emerging out of Harvard to align it so that you could run a HERON query, and then after it ran here, it would automatically go over to Milwaukee and Dallas and count and count and count. It takes a fair amount of work to get that set up right, and it restricts you to just the terms. You have to all agree upon what you call everything. So we like that, but we think it's going to take us a long time to get everybody to call everything the same thing right away. Whereas being able to copy your query up just quickly offers a fair amount of value right away. So that's a first sense of some of the things that you can do. The other thing is, as you talk to people who are looking to do prospective trials, it's an opportunity for us to help figure people out. Can some of the technology or these approaches to engaging the other sites help you do a more competitive multi-center trial proposal than you could just by yourself? Any questions or comments? Everybody's tired. It's been a long day. Yeah? To Babel? What you would do is, what we have right now is we just have, what do we say? There's a button there that says request password, and you put in your email address, and it will go to you. Just, email Tamara, or you'll see on the HERON homepage, there's the HERON. Did we tell them about the Gripe button?
We did not.
Okay, so she doesn't want to tell you about this. When you're in HERON, you'll notice both within the tool, there's a Gripe button, as well as when you're on the main homepage, there's a help button. You're always welcome to just use this tool to put in a question or comment. So if you saw Babel and you can't remember Tamara's email because you don't want to let people know what it is, you can gripe and say, hey, I saw this Babel thing. My name is Bob Jones. I'm at Children's Mercy. My email is blah. Can you create an account for me? And then she'll triage that and create an account for people. And that same gripe button, we call it gripe and praise, because you may want to say something wonderful like, praise. Thank you so much, Lee, for helping me on this, or Tamara on that. You can go either way.
Yes.
And it's the same form. And also it's the same form we have on our RegCap page. So if you had a question about RegCap, you can do the same thing here and let us know how you want to be contacted.
I understand, so that from what you've said, like another from Milwaukee would send something to Tamara. In the same way, let's say a person at KU had a question, either Texas, Iowa, or Milwaukee, with that same request would be like Tamara's counterpart.
Right.
Correct.
So what we're trying to work out is, at the more logistical end of things, we as campuses are very set up to serve ourselves, but we're typically not very much set up to serve other people. So we're trying to get this technology built and the people process built to approve stuff, and then figure out, over time it ought to be only a couple $100 for you to kind of ask Milwaukee, I've already well-defined my population. I'm looking for collaborators to work on the burn unit comparison, right? So you may say, I'm very interested in burn care at KU, and you could be browsing HERON and building out a very nice query to look at the burn population. And then you want to go up to Milwaukee or to Wisconsin or Minnesota and say, do they have comparable data that we could work on together to do a larger study? Or if you already have collaborators there, you may say, I'm already working with this guy. We may want to work together on a project. So picking on Milwaukee, when I went up to visit there, they actually have been working a little bit in critical care together with Steve Simpson here. And it hasn't fully formed, but the goal would be to kind of look at some of these issues of what's comorbidity and sepsis look like in the Milwaukee population versus the Kansas City population, and do the treatments vary. So our goal is to try to make it so that without huge cost, when things are built in a consistent way, it's easier for you to replicate and get data sets, which you'll talk about next.
Right.
Okay. All right. Well, thank you, everybody. Yes, Ann.
Hey, Brett, so if you're, let's say you're interested in a very, small population, and you don't know who the collaborator is at Wisconsin or whatever. So if you build your query and email Tamara, and she hasn't run it, and they have 150 patients with blah, 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 can they tell you who is seeing those patients or what clinic they're being seen in so you can contact that person to be your collaborator?
That's our next goal for phase 2. And that's actually right now I'm working on turning in a NIH proposal to help with recruitment, and that's a huge gap I've identified, is that a lot of this searching stuff is done, but we don't really put the tools in place to make it easy to tell. You know, your dream situation is you want to find out where are all the obese children at high risk and blah, 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 blah. You want to go to Milwaukee and say, okay, how many are there, and who are the top physicians, and ideally, who are the top physicians who also publish? So you know, because you could find out their top physician who is doing this work in Milwaukee is so busy clinically, they don't care to get involved in research. So we want to try to help solve that problem by kind of taking in who are the people actually doing research, who are the people seeing the patients, and then when you search with these tools, you know, that's the right lady that you should be working with. So what we can do in the meantime is, if you have a project you want to develop, on the main we have gpcnetwork.org as our main homepage, and you can put in a request. So if you're developing an idea or a project, you can put it in, tell us what your role is, and then if you're looking to collaborate with people, let us know, you know, or if you're seeking collaboration, we can at least start the process for how do we connect you to people that might be good collaborators. So we're working out that. Yes, Vince?
Yeah, Russ, during the workshop, I had a question, or somebody asked me, and I thought maybe you could speak to a little bit more. You might have touched on it already, but just in terms of like the usage of I2B2 across the country, certainly really strong within the GPC collaborative, but kind of where do we stand in volume use of that compared to other folks across the nation?
That's a really good question. So if you were to look at it, we were just at the annual meeting, and there were more people in attendance than ever before, but it's hard to get a real feel for how much at a given site is it really being used and how is it being used. So that's like on our page, that's one of the things we wanted to do right away, is this page, who's using it. So we kind of put it right out there within KU. You can get a feel for how many people are using it, how much they're using it lately, and how much it's being used every month. I have a feeling, and keep in mind too, we're a relatively small academic medical center compared to, say, University of Washington or Harvard across all the schools. So I've been informally, some places run a lot more volume than us. Other places that are really big, they use it, but in very niche little projects. So I think we are probably one of the best places in the country in terms of having the most rich data. There are other places that have it very deep dive in specific areas. So Thomas Jefferson Kimmel Cancer Center has some really rich data on biomarkers, but they don't have the volume of usage we have. So, but what was interesting is that there were more places in attendance, and there's a lot more CTSA interest in broadly adopting the tool. So I think there were there's probably over 100 places using it. The other comment I have to make is, has anybody ever seen the movie Monty Python and the Holy Grail? Okay, you remember the scene where they go up to the French castle and they say, we seek the Grail, and the French say, we already have one? That's kind of like I2B2 in technology tools, and it used to be that way a lot with EHRs. People say, oh yeah, I got one. But then you'd actually, if you got behind the castle and looked at it, they had one, but no one was using it, right? So there's a lot of people who've downloaded the software and may have installed it, but you almost have to go back later and say, well, you know, how many queries are being run every month over what types of data to know how richly they're using it. So I think we're probably in the top 10% of places that are using it, but that's just my initial sense. As we work through PCORnet and as we work through efforts in the CTSA around recruitment, the truth is going to really come out to see where are the places where they're really using their data together. Very good question. Thanks, Vince. Okay, off to data delivery, and I'm going to run to a call. But thank you, everybody, for coming.
Thanks, Russ. Okay, so I'm going to talk a little bit about data delivery. So once you've created your queries, you got your patient numbers, that's great. You want to take it to the next step and look at the data. We showed you how to request the data, whether you're requesting contact information or if you want data for analysis. So I'm going to talk a little bit about the data you receive for analysis. And let me go into HERON to show you an example. So when we run the data for you, we provide data on every concept that's in your search. So you want to load that search up with all the types of data you want. And we deliver it in REDCap. So let me go down here. Okay, so here's one example. This is a breast cancer example. They're looking for breast cancer within a certain date range. It's from 2010 on, limited to African American females. And then this is kind of a bucket of all the types of information they want. So in this search, the requirements are breast cancer, African American female. And then they could have smoking tobacco or lymphedema. They could have mastectomy, just on and on and on. So not every patient is going to have every item in group 4, but if there's any data for that patient for these items in group 4, those people wanted it. So in REDCap, we log in. And this is a de-identified data set I'm going to be showing you. In REDCap, this is how we deliver your data to you. You receive a REDCap project that has, over here, this is the folders for what was in your search. So if you look at this one's from demographics, this one is history, diagnoses, and so on. So, oops, sorry, I've got a lot of tabs open here. Close some of these. Within the REDCap project, if you get a general patient, again, like I said, this is all de-identified data, so we'll just go with this first one here. This is the de-identified birth date, age, gender, African American, religion is unknown, and it gives you marital status. We've also got the cancer information. She pulled this from the abridged cancer cases, and this person has had this cancer diagnosis attributed once. It's got the first date and last date, and then it pulls in the label so you know what you're looking at. And then you drop down to diagnoses. This one's going to be a little longer. This post-mastectomy, there's no data recorded for this patient, but this person does have hypertensive disease. So they have recorded 5 times in their record. It shows you the first date, the last date, the diagnosis. This one is the modifier that's attached to it. So this one was actually, the last time it was recorded was in this person's medical history. This person also has diabetes, which was recorded 6 times. First time in February 13th, the last time a year later in July. Again, anytime there's any type of value associated with it, it will show up as well. This will show you this person had smoking tobacco, and they're recorded as never smoking. If there's a BMI reported, it will show you that last numerical value. So with this, it gives you kind of a high-level overview of your patient set. You can then take that data and create some reports. For example, in REDCap, we went in and we decided we're going to go ahead and for this patient, do their birth date and the date of first diagnoses. How many times they've had hypertensive, diabetes, how many times they've had these comorbidities diagnosed. It's got smoking use. So this gives you an overview of that patient set in a report format. And then we went ahead and created an age at diagnosis. This person was interested at the age of diagnoses and what type of comorbidities existed within that time frame. And then from here, you can go in, for instance, this one has hypertensive recording 210 times. Maybe you want to learn a little bit more about this information. From here, you can drill down into that person's record a little more. So that's kind of a high level, because when we pull it into REDCap, there's a lot of questions. Do you want the first diagnosis? Do you want the last diagnosis? Do you want the cumulative value for BMI? Do you want the last value, the first value, value at diagnosis? So there's a lot of information when you get that raw data that we try to summarize in the way that most people requested. For instance, last value, how many times was it diagnosed, first, last date, we provide that information. Let me show you another example where, for this person's research, this worked just fine because they were doing kind of a high-level diagnosis of these breast cancer patients. How many had hypertension? How many had a BMI over a certain amount? But they weren't wanting to look at the timing in detail of such things. So there's another example for an aspirin data set here. And this person, they did not want any children. They were looking strictly at adults, and they were interested in clopidogrel use and aspirin for people who have had stents. And let me bring that one up. So this person received the data, and again, she was looking at all of the different recordings. But as she was going further into this research, for instance, clopidogrel was 63 times. She became more interested in aspirin use. This one was 86 times over a 2-year period. What she decided to do was narrow down her research a little bit more, and she wanted to look strictly at a timing event. So if this was an inpatient stay, what was the aspirin an outpatient order or an inpatient order? I know for the outpatient order, how soon? She wanted to see those patients that had an outpatient order for aspirin within a week of that stent placement. So you can't do that with this data in REDCap because you can't get down to that level of detail. So she had to go to the raw data. Within REDCap, we always attach the raw data as well so that you have the option to go to the raw data if you want. So I'm going to show you an example of what the raw data looks like. You'll get 4 tables. You'll also get some code to where you can create a SQL database if you're familiar with SQL and can. This person went in through SQL and pared down their data set. The moral of the story with all this data is when you're creating your queries, think ahead about how you want to analyze it and how, if you're going to be using SAS or SPSS, if you have skills where you can narrow your set down in SQL, if you can do it at a higher level in REDCap. Just like I2B2 has a lot of options to the way you can create your query, we also provide you a lot of options for how you can analyze that query. So when you embark upon the data analysis, you really need to think through how you're going to analyze it, who's going to analyze it, and what format you want the data in, because we give you a couple different options. So for the raw data itself, you get a patient data area where you've got all the patient numbers, the birth date, a death date if there's one recorded, all your general demographic information. You also receive a variable table which will list the name of the variables that were in your search, and these are the data elements that you're receiving as well. Then you also receive a code info table, which looks very similar to the variable table. And then you also receive the data table. And this is the big one, and this is the one that you will analyze. So what this one is, you can see for this patient, this first patient listed here, number 1759518, this encounter number, all of this happened within this person's encounter. And you can see there's multiple observations. So when you say, I want to know their clopidogrel usage and their hospital stay, how do you want to define that? You can see there's multiple dispensed. This was dispensed quite a few times. You can look at, we're giving you all of those modifiers in that search, whether you, in this example, it's whether you want them or not, because we're giving it all to you so you can decide how you want to define that medication. In the future, you'll be able to tell us, no, I only want the dispensed information, or I only want the orders. So you can see in this one, in just this one patient in one day here in 2013, how many dispensed orders of that clopidogrel you have. Each line represents an observation. It's got the start date, it's got the end date, it's got the variable name, it's got the value, so you can see what dose they're receiving. This is currently, this is all just the clopidogrel information. Let me try sorting this to give you a little different view of it. We're going to go by patient number and then by encounter number. Go back up to the top. So this will show you within, let me bring this modifier over a little bit more. So within this one encounter, within like 82703, all of these clopidogrel, aspirin, it gives you a line for each observation. So if you're trying to analyze this data, you're not really going to be able to do it in Excel. You're going to need to use something like SPSS, unless you have a very simple search. You pull these raw files into an analysis software. What the person did for this one, like I said, when they got this data, they're like, oh my gosh, this is a lot of data. How do I, it really made them think how they want to narrow down their research. And they were interested, as I said, in just focusing on the aspirin with orders within a week of the stent placement. So they pulled this they created a SQL database, narrowed it down using some SQL scripts, and then they ran some R code on it, which is a tool similar to SPSS or SAS. And they were able, from that, to bring it down and get a little, make some sense of it, get some vital status, get some visuals for this, their race, their procedures, how many, here we go, you can see they narrowed it down to the aspirin, and they included both 81 milligrams and 325. What I'm trying to display to you in this portion is you get a lot of data, and it will take a lot on the analysis side to use it, but you really can do a lot with this data. You're not limited. You're getting all of it. You're getting the raw data. You can use it to make all kinds of discoveries. Does anybody have any questions about how you receive the data? So when you do a request through the RRC, all you get is a nice spreadsheet with just the contact, the name, the address, the phone number. That's it. When you do a request through the DROC, the Data Request Oversight Committee, that's when you get all of this raw data and you get the REDCap projects. Like I said, some people can do all of their analysis within REDCap and they don't need anything else. It's great. Some people have to go to these raw data files. So that is what I wanted to show you about data. We're on to the closing thoughts. You guys have been troopers. This has been a long day with a lot of information. You guys have been really good through all of this, absorbing all kinds of information. Does anybody have any closing questions, comments? Yes?
So we've already done one study across KUNet and CMH.
Mm-hmm.
Can we do the same exact study but with all the GPC sites?
Yes.
So you can keep the same query?
You can keep the same query. The GPC has a data request oversight committee as well, so it's the GPC DROC. So it's the same type of situation. You submit the request, a committee reviews it and says this is great, and institutions can agree to participate or not. And you can also select which institutions you're interested in participating. For instance, you may not be interested in Texas, so you wouldn't select those institutions. But yes, then they would recreate that query as close to possible as ours. So that's why we're trying to make those paths align, so it'll be a quick, robust search across all sites. All right. Yeah. What's the question? If a researcher wants to. Okay, so if you do want to get data from other sites, let me bring back up the GPC website. There is a gpcnetwork.org site, and on the bottom there is a request form, and this is where you can register your project. You can say you're interested in getting data across sites. It's great to work with your honest broker at whatever site you're at. So at KUMC, you'd work with me, and I would make sure the query is working here and we've got it in place. And then once it's done at our site, you would then submit a request to the GPC DROC, which is the next step. But the first step to do is to fill out the GPC request form. Just so we can get that project going and make sites aware that this is an upcoming project. Yes.
Charlie and I both looked at this topic,
Mm-hmm.
and it looked like some of the sites on the GPC had facts and data that we could use, and some sites had nothing.
Right.
So if we wanted to, if we could just move by and scrape, okay, these 6 sites have data we might need, then we just include those 6 sites in our
Correct.
tool, that's all we have to do.
That's all you have to do. That's correct. And that's the nice thing about Babel is that, and why Russ suggested get an account and get in there and look and see, you know, if you're dealing with pediatric or rare disease, you can look and see which sites actually have patients with those diseases. Because there are some sites that won't have the data for every disease out there. Any other questions? Yes.
So just take my own example.
Mhm.
I study that it's already approved over at CMH. I've crossed it over here. It's approved over here now. All the data and I've crossed the point data at both places. 4 sites that have the same data elements, like pull the exact same stuff.
Right. So one step of the process, you know, like I said, we've got the data oversight committee, but prior to that, there needs to be IRB approval. And the GPC sites have worked through regulatory. So if the other sites defer to your IRB, then there's no issue in pulling that data. And it would be whatever is defined in your query and in your IRB protocol.
Is it similar? Is that, I'm assuming it's not the same as like the CTSA agreement that like KU and Children's has, which is essentially a request for a line.
It kind of is. I mean, there's a committee, a GPC IRB committee that does review. Each site reviews it, and they have the option to defer to it or not, which has been a process that we've worked out. And it's starting to run a little smoother across all the sites. It's amazing when you think about all the regulatory for each institution agreeing to defer. But we've come up with a common data sharing, a GPC data sharing agreement, IRB reciprocity. So, yeah. You should be able to do that. Correct. Right, and that's why I suggest you work with your honest broker at your site. So you need your IRB in place at your site, and then once it's there, you can bring it up to the GPC level. But we request that people get all the bugs ironed out at their site first before bringing it to the GPC level. Mm-hmm. All right. I guess my closing comments to everyone is thank you for hanging in here with us. It's been a long day with a lot of data and a lot of information thrown your way. We do this about once a year. We're thinking about possibly doing it more. Can I get a quick feel? Do people think there should be a 1 day or 2 half days? Is it too much for 1 day? No, you think it works in 2? I've passed around surveys. If you could put any information, if you think we need more presentation in the beginning on search types or more hands-on training, we'd love the feedback. Yeah, I guess that's it. Thank you for joining us. If you have any questions, the handout has contact information. My card is over there as well. And within the HERON website, let me log out here. We also have, as I pointed out in the beginning, Lunch and Learns on the first and third Tuesday of each month from 12 to 1:30. You can come in on a drop-in basis. You can register in advance if you want pizza. And we've got the informatics project request form. If you want a group training for your group, you can request. We do 1-hour trainings for a group. We also have questions and concerns can be sent to our HERON admin address. If you need to move, if you're interested in moving a Red Cap project into HERON, that's done through the information project request as well. And I think that's it. Thank you for joining us.